Well, Tim, we installed the machine this year and we treated already some patients, but it's too early to show our results. Therefore, I will show you my logical or rational approach to the therapy. And I will start with a very simple question, which is, what do these guys have in common? Well, they have in common that if they want to be successful, they have to get the target. This try was not successful. And this try will probably not be successful with the Oraya therapy either. Actually, why? We know we have substantial clinical and experimental data that radiotherapy is anti-angiogenic, anti-proliferative, and anti-inflammatory. However, you have to think about that's different from drug therapy. It's a mechanistic approach. It's a mechanistic approach like it was PDT. Therefore, you have to take this into mind. With the Oraya therapy, we have probably the most accurate technique to deliver radiation to the eye. You deliver 90% isodose within an area of 4 millimeters. Of course, if you choose a membrane which is larger than this irradiation area, then you might miss the proliferative edge. You will have untreated areas of the membranes, which of course will then end up in a recurrence. And this is what we see from the INTREPID study, from the subgroup analysis, that if the lesion size is smaller than 4 millimeters, if you have it inside the area, then you have fewer injections, you have better visual acuity recovery and less fluid. How do you choose your patients? Of course, the usual techniques. You look into the eye, you perform fluorescence angiography, which is very crucial for this technique, I think, and you use OCT. You can measure with the new very well if the lesion will be inside the area, and do we have sufficient patients to be treated this way? Well, if you look at older papers, publication, we know that within the first year of diagnosis, there will be many patients, almost more than every second patient could be treated with the Oraya therapy. But if you wait, of course, the lesion becomes larger and might not fit anymore for Oraya therapy. And what also happens, of course, if the lesion is aging, you will get fibrosis. And what we know is that if you do not have fibrosis, you will have better results. It's easy to understand if you look what a fibrosis is doing or what Oraya therapy is doing. If you perform, maybe you can take out the active part of the disease, but if there are degenerative changes already and over the scar, the radiotherapy will not change it. And the radiotherapy will not change either the size of the scar, so you will have not the same reduction in lesion thickness than it was without radiotherapy. Another problem with fibrosis is, as you know, that the growing of the lesion is centrifugal, meaning you have a central core which is fibrotic, and you have a peripheral part, a proliferative edge. And here it is important that you really look at fluorescein angiography. Where is the edge of the CNV? Is it covered by the radiation, yes or not? Here some patient who might fit within this therapy. This is a patient who had recurring subretinal fluid, and he received PRN strategy from us. He received 3 injections, and when he was dry, he even had a vision of 20/20. But after 1 month posing the therapy, 2 months later, he had again fluid. So we performed PRN and needed, in this case, 9 injections per year. You might go and treat an extender, try to measure it, and it would be also 9 injections per year. In this case, where the patient every 2 months without therapy had subretinal fluid, we decided to go bi-monthly, and this was successful. It was dry with every 2 months injection, but still he needed 6 injections per year. And I think this is a wonderful case who might be successful with the Oraya therapy. Many colleagues often ask me, is this therapy for non-responders? what are non-responders? The definition is not so easy. Is this a non-responder patient with, we injected every month, we and the other doctor, and still had subretinal fluid. When we stopped, we discontinued the therapy, the fluid became more. So there is some kind of response to anti-VEGF therapy. So this might be a patient who might fit for Oraya therapy, but it's very important that you look again at the size of the lesion in order to know if it fits or not. A different patient treated with aflibercept, 3 injections, wonderful reaction even already after 1 injection, but 2 months after the last injection, again subretinal fluid. How do you continue? Do you do it bi-monthly or do you do it PRN? We looked 1 month after the 4th injection. It was again subretinal fluid, so we treated it for 3 months. And then we turned back to bi-monthly. And doing injection every 2 months, the patient did not become dry. And even by reducing the number of injections, there's one point, and you know it, when your patient will come for you and ask, is this a never-ending story? So we try to tell him, this is a chronic disease. Maybe this is the time point when then you have to tell the patient or to talk them about their Oraya therapy. More good reasons for radiotherapy. These are the data from Germany, from the AURA study, showing that though we have a good result with anti-VEGF therapy in visual acuity, the visual acuity will then drop down over the next years because the patients do not come to the doctors to get to not sufficient injections. And if the patients that we are treating today are old, they will become much older in the next years. And so they maybe not come even if they are willing, or maybe if the persons, the social support, will not be able to bring the patient to the clinic. So if there is a way to reduce injection therapy, I think Oraya therapy for the moment is the only one. Thank you so much.